Welcome everybody to another CanSAGE webinar. We're so excited to have you as we talk about a topic that is near and dear to our hearts as gynecologists. We're going to be talking about the management of iron deficiency anemia in gynecology. Before I introduce my guest, I'd like to introduce myself. My name is Singh. I'm a professor at the University of Ottawa in the Department of Obstetrics and Gynecology, and I focus on minimally invasive gynecology and surgery. Now, we're going to be together for approximately 1 hour. If you would like, we might have some time to go through a few more extra questions, and I'll give you an update as we go through. But before we get started, I want to tell you a little bit about CanSAGE, the Canadian Society for the Advancement of Gynecologic Excellence. You can find us at cansage.org. Please consider joining us for our annual meeting, or join us through cansagevideos.com to learn more about gynecology in general, surgical gynecology, all free. Now, before we get going any further, I wanted to just share with you that there are educational grants that were provided to allow us to run these webinars and symposia. Now, the providers are there who have partnered with us, and they're not involved in the educational content, and yet at the same time, we couldn't do this without them or without your support. And don't forget, membership is very important as well. So if you'd like to be a member, find out more on our website. A couple of things just for housekeeping as well. This session is being recorded and will be posted on our website for you to review later on. The evaluation that will be available online later on will allow you to get the Royal College credits for attending this session. And finally, I do want to thank all of you who took the needs assessment survey, and Dr. Kelly Whitehill is our winner from BC. She'll win an Amazon gift card, and it helped set the stage for what we're going to be talking about today. And also one special thanks to Dr. Catherine Allaire, the CanSAGE president, Dr. Jamie Croft, Dr. John Teal, the CanSAGE board members, and the online educational planning team for making these sessions available, and of course to the CanSAGE administrative and technical support team. So let's go ahead and introduce our speakers today. First of all, I'd like to thank Dr. Ali Murji for joining us. He's a great friend and associate professor in minimally invasive gynecologic surgery at the University of Toronto through the Mount Sinai site. He graduated from the University of Toronto, but then completed a fellowship in minimally invasive gynecologic surgery with Dr. Nicholas Leyland at McMaster University. His training focused on minimally invasive surgery, including hysteroscopy, endometriosis, and outpatient procedures. And of course, he completed a master's in public health from Harvard University. He's not only associate professor, but he's also a clinician scientist at the University of Toronto. Thank you so much, Dr. Murji, for joining us. I'd also like to thank our special guest, Dr. Karima Khamisa, who is a hematologist, and she received her degree at the University of Western Ontario, where we were actually in school at the same time. She then went on to do internal medicine at Queen's University and hematology training at University of Ottawa. She now has been part of the Division of Hematology at the Ottawa Hospital, has been essential to my own practice, has taught me a lot and helped thousands of women in this area, and we certainly have benefited from her. But more importantly is her role as an educator. You can find her on Twitter, you can find her on YouTube videos and other websites teaching the essentials of hematology, and today we are fortunate to have you join us as well. As I move forward with the slides, I just want to let you know that we have some disclosures that have been posted as well for all of us, and those are shared here. Our learning objectives at the end of this session will be the ability to indicate the use of various oral iron supplements in the management of women with iron deficiency anemia. We want to be able to outline the indications for IV iron in the management of this condition, and recognize and manage possible side effects of IV iron products. And again, this is all accredited, so you'll have a chance to look at that later on and get your points for 1 hour. So without further ado, Dr. Murji, thank you for joining us, and I'm going to hand it over to you.
Thank you very much for having me here today. What I'd like to do over the next little bit, and what I'm hoping that you'll get out of this, is that we want to bring to life the management of iron deficiency anemia and really relate it to our gynecological practice as we have it. And we're lucky today to have Dr. Khamisa with us, because so often we just want to pick up the phone and call the hematologist and ask all the questions that we may as gynecologists be a little bit embarrassed to ask. And I'm hoping that through this case-based approach, we'll bring to life some of these learning points. So I wanted to start with the case of Miss L. She's a 37-year-old gravida 1 para-0 lady of Asian descent, and she was referred for fibroids and heavy menstrual bleeding. She has a past medical history of hypothyroidism, for which she's on levothyroxine. She's had previous 2 failed hysteroscopic myomectomies. She has no other drug allergies. She reports her menses to be regular every month. They last 5 days, and she says that they're heavy. When I search back into the referral, sometimes we have it, sometimes we don't, but there's a hemoglobin done by the family doctor a couple months back, and that hemoglobin was 90. So as gynecologists, we're actually very good at asking about the details of a patient's menstrual cycle and about her menses and how heavy it is. And we all know that based on the standard definitions, it's 80 cc's of blood per menstrual cycle, and more than that is classified as heavy menstrual bleeding. But that makes no clinical sense. And what's really clinically important is the effect that that bleeding has on a patient, on a woman's quality of life. So asking questions like, how many pads do you use? Do you wake up in the middle of the night to change products? Do you have problems with soiling linens or clothes, and how frequently? Do you need to stay at home because of your heavy menstrual bleeding? Do you have flooding or clotting? These are questions that we're all used to asking. And I do refer you to this website down here, and a lot of us give talks on heavy menstrual bleeding to medical students and colleagues. And this website, heavymenstrualbleeding.com, is actually excellent and has wonderful resources for us and also for patients. So although we're pretty good at looking at and assessing a woman's menstrual cycle and how heavy it is, what we have to remember is that approximately 2/3 of women with heavy menstrual bleeding actually had iron deficiency and or iron deficiency anemia. And in fact, less than half of them were treated with iron. What we're not so good at as gynecologists is really asking about the iron deficiency symptoms. And so the one challenge that I have for you, and if you're not doing this already, in the next patient that you see in your clinic with heavy menstrual bleeding, ask at least 1 or 2 of these questions when you're inquiring about the menstrual history. Do they have ice craving? Do they have issues with their hair in terms of their hair falling out? Do they have headache, poor concentration, restless leg syndrome, fatigue, cold intolerance, exertional dyspnea? These are all symptoms of iron deficiency. And you'll be surprised that if you start asking these questions, how many patients will report some of these symptoms. So when we go back to our case, the patient does report that her periods are heavy. She reports that it is having an impact on her quality of life. She's homebound during her menses. And when we look at, when we ask about those questions of iron deficiency, she reports fatigue, lightheadedness, cold sensitivity. She denies any bulk symptoms, and we examine and find a 14-week size uterus. So the question is, treatment can we offer next? And so I've set this up in a 3-step approach. The first step, and many of us are surgeons, is stop the bleeding. And I think that that is perhaps the most important thing that we can do for this patient who's debilitated by her period. Second, treat the iron deficiency, and we're going to go into detail about that. And third, which encompasses 1 and 2, is plan for surgery, and plan for a safe surgery. So as gynecologists, and we're all part of this society, we are no strangers and we know this extremely well, that there are hormonal approaches and there are non-hormonal approaches that have a significant impact on the menstrual blood loss per cycle. But as a review, what I'd like to draw your attention to is that some of these non-hormonal options, the non-steroidal anti-inflammatories, the cancer.
Dr. Murji,
Yeah.
sorry to interrupt. I just want to make sure you're not touching your mic. It seems to be a bit muffled.
Is it cutting out? Is that
That's
better?
better. That's better. Thanks.
Perfect. So some of these non-hormonal approaches actually have a significant decrease, 50 to 60% decrease in menstrual blood loss when taken with menses. Of course, there are the hormonal options, which are the oral contraceptives, the levonorgestrel intrauterine device is effective, danazol, gonadotropin releasing hormone agonists, and until recently, we also had selective progesterone receptor modulators, which were very effective. So step 2 is treating the presumptive iron deficiency. And this patient came in with a hemoglobin of 90, so clearly that we want to treat. And the first step in the approach of treating the iron deficiency is an oral option. And this is where, as a gynecologist, I'm always confused as to what should I prescribe as a first-line option for these patients who I know have heavy menstrual bleeding and are suffering from iron deficiency and or iron deficiency anemia. And so this is where I'm going to turn it over to Dr. Khamisa for help to help us sort out what is the first-line iron supplement that we should be using.
Thanks, Ali, for that. And that's an interesting question, and it forms the bulk of my practice. I have 280 patients actively being treated for iron deficiency. The bulk of them are women, 80%. So the first question I often get asked from women who come to me is, why don't I just take more iron through my foods? Why can't I eat more spinach? I'm doing everything right, doctor. I'm eating cereal. I think it's very important as gynecologists and hematologists to understand that the degree of iron deficiency that we're dealing with in our shared patients is actually fairly extensive. The typical amount of iron that should be taken in by a premenopausal woman, let's say they're not having excessive heavy menses, is about 18 milligrams a day. And not much of that is absorbed. Typically, only 2 milligrams a day of that is absorbed. And in one heavy menstrual cycle, you can lose up to 20 to 30 milligrams all at once. So I think we have to really emphasize to women that diet is often great for prevention. And they may come back to you after months after having their IUD placed, where their menstrual losses are slowed down and their hemoglobin's improved. And they're a little bit iron deficient in terms of their ferritin levels being a bit low. At that point, you may want to think about if they're really intolerant or unwilling to take oral iron supplements. I think at that point, dietary measures become important. And then you can talk to them about non-heme iron sources, such as what's found in vegetables like spinach. Now, with non-heme iron, you're very susceptible in terms of absorption issues, in terms of what other co-ingestions they're taking, in terms of what other food items have phytates, tannins. So there's a lot of variability with vegetable sources. Meat sources have a type of iron called heme iron, which is a bit more bioavailable. And some of the iron tablets that I'll be talking about later utilize that increased iron absorption property. The mainstay of treating iron deficiency in our shared group of patients, the first line is always going to be oral iron supplements. And I'm talking first line in terms of our stabler patient. Perhaps they're not in a rush to pursue a surgical manipulation or surgical intervention right, in the next few weeks. If we're dealing with a patient who you're seeing as an ambulatory care patient, I'm seeing as potentially an ambulatory care patient, who has never tried anything before, who doesn't have an imminent surgery planned, I think the first best choice is going to be an oral iron salt, something like ferrous sulfate, something like ferrous fumarate. And we'll go through a little bit about what dosing might look like. I would advise that if they're significantly iron deficient and they've got an anemia with that, to take iron salts every day. And there is going to be questions perhaps at the end about the every other day issue. Now, I want to refer to that study that does talk about every other day oral iron salts, and they use ferrous sulfate in that study. That was in non-anemic women. We are still waiting for results in anemic patients to extrapolate that every other day dosing. That research is actually excitingly being done by my colleagues at University of Toronto, called the DIODO trial, and we're hoping for results in the next 2 years. But until further evidence, until we have that evidence, in my anemic patients, I try to get them to take, at least to start with anyways, an iron salt daily. If you can, there are some data indicating that morning dosing is better instead of QHS or nighttime. Now that's again subject to variability in patient preference. Some patients prefer to take it at night, and that may be perfectly reasonable. Once a day dosing. So many iron scripts say TID, BID, or some people reflexively order multi-day or multi-time dosing in a day. And the evidence somewhat extrapolated from, again, other populations that are perhaps not as iron deficient indicate that once a day absorption is just as good as BID dosing. So if they can stack that iron, and perhaps not a lot all at once, but at least 1 tablet, 2 tablets, if they're going to take 2 tablets, try to put it once a day rather than BID, TID. Avoiding certain medications. So when we think back to the case, this patient is actually taking thyroid pills, and thyroid pills and iron do interfere with each other. So it's very important to counsel patients and look at their other medications. What are their co-ingestions? If they're taking their iron tablet pretty religiously, tolerating it, but they're washing it down with dairy or milk or calcium-containing products, they aren't going to get benefit from that iron salt. And people say, well, what if I switch to a polysaccharide or another type of iron? All non-heme iron products, be it polysaccharide iron, which is Ferromax, or iron salts, same thing. They're all susceptible to this interference with absorption. This is often why people prefer parenteral iron when they're dealing with patients on multi-medications. The issue of vitamin C is an interesting one. And we've got a recent JAMA article from 2020 indicating that perhaps vitamin C may be foregone. If you don't have it or you do have it, absorption appears to be fine and just as good in the ferrous sulfate products. Now, that data is from a different population. It is an RCT, but it was run in a different country. It was run in China. And so there is an interference perhaps with green tea or other type of products that we may not be able to fully extrapolate to. And of course, I deal with a very different group of population that are often very food restricted, bariatric surgery patients. I've diagnosed scurvy in over 15 patients in the past 10 years. I give parenteral vitamin C. I do deal with a more complicated group of patients that I do feel still that there may be some benefit to adding that vitamin C on. But if you don't, or your patient can't afford it, please refer to the data below that it may be omitted. The issue of side effects comes up with oral iron salts, and constipation happens in 20% of patients, and we can anticipate that when we're prescribing iron salts. And you can tell them about this. You can say, make sure you increase your hydration. Iron sucks out water from the bowel, so it's really important to keep extra hydrated when you're taking iron supplements. And if you get a little bit constipated, which can happen, think about taking PEG or polyethylene glycol. The slide used to say take stool softeners, but somebody at one of these talks said, well, stool softeners like Colace don't really work. Laxatives are more effective. I researched the evidence, they were right. So those are some things you can anticipate. If you're starting oral iron on a patient, you can recheck their parameters. Now, I typically like to have my CBC ferritin drawn before starting oral iron therapy. You may not have the luxury of that right now. I would simply start in a woman with heavy menstrual bleeding. If you're able to, or that baseline data is available, wonderful. Then recheck that level in about 2 to 4 weeks. That may be more practical for you to check in 4 weeks if that's your practice. I say 2 weeks because of course I'm seeing very severely anemic patients that need a little bit of they're a little bit higher acuity. They probably need a little bit of a closer eye. So in my practice, that's what I would do is perhaps a little bit more frequent. If there are no excessive losses, you should expect the hemoglobin while on a tablet or 2 tablets a day of oral iron to go up by 5 to 10 grams per week. And it may require months to replete their iron stores at that rate. When we're talking about iron salts, I think we all have some familiarity with these 3. These are the ones that are available if you go to the pharmacy. They're not actually by prescription. You can buy them. They're so-called over-the-counter, but they're really kind of behind the counter because iron toxicity can be an issue for young children. So the pharmacists tend to hide it behind the counter in our province, at least. And these are cheap, pennies a pill. I prefer ferrous sulfate as my go-to oral iron supplement, and there's going to be quite a bit of debate, I can imagine, with people with years of practice having great experiential evidence with all the iron salts. But I find ferrous sulfate excellent. It's a great Canadian compromise. It's the Goldilocks iron salt. It's not got a lot, it's not got a little, it's just in the middle. It's what all the clinical trials use. So if I want to extrapolate evidence from clinical trial data, it's often ferrous sulfate that they're using, and it's only 4 cents per pill. So it's cheap, it's inexpensive, it's got a decent amount of iron, and the more iron you have in your iron tablet, the more side effects you might get. So it's sort of that middle of the road. And of course, the side effects we sort of went over as constipation, but people can actually have diarrhea. And I've seen that before with iron tablets. They can have heartburn, nausea, funny taste in their mouth, and some people even have anticipatory nausea where just looking at iron tablets can make them feel ill, and that's the kind of people that I often get referred to. And remember, only 10% of iron is absorbed. There's a bit of a misconception about these other more expensive iron products, and I do like to use them too. I find they have a role. So when somebody's perhaps not tolerating the iron salt, perhaps these second line iron formulations are a little bit better. Polysaccharide iron is also susceptible to issues of absorption. It is a non-heme iron product, so it is no better absorbed. And there is one clinical trial in JAMA in children actually indicating it's less absorbed. That was in 2017. So I do use it. It is kosher, it's halal. Just remember the iron salts may have fillers in them that are pork or have other products in them. So if your patients with religious restrictions, please inquire into that. And if that is an issue, certainly feel free to offer them the Ferromax, which I believe has got those approvals. And in terms of a little bit of a test for everybody, I'm going to start a poll just to see if anyone's listening. So I'll read out the question. You won't be graded on this, there's no marks. Assume a patient is anemic with a hemoglobin of 90, that was the case here. You initiate ferrous fumarate, 300 milligrams daily, with vitamin C 500 milligrams taken every night. If oral iron was successful, what rise in hemoglobin would you expect to see if we repeated the CBC in 4 weeks? Answer A is 5 grams at the end of 4 weeks. Answer B is 10 grams. Answer C is 15 grams. And answer D is 20 grams. And we'll wait.
Thank you, Dr. Khamisa. We got quite a few responses there, just a couple of last ones there. So I'm going to end the poll now, and I'm going to share the results with you so that you can see them.
Wonderful.
Do you see the results there?
Yes, and I'm going to read out the results. So 11% thought that you might get 5 grams, and it's not quite correct, although I'll explain why later. Answer B says 10 grams, and 23% thought that. Answer C is 15 grams, 1% thought that. And the correct answer is D, and 65% of folks picked that answer. So I'm going to stop sharing that result, and I'll go through that. So if there's not any major ongoing excessive blood losses in an ideal world, every week that you're on oral iron supplement, typically 60 to 100 milligrams per day of elemental iron, you would expect to see a 5 to 10, increment. So if we take the least, amount of absorption possible, 5, multiply that by 4 weeks, one would expect 20. Now, if we're really lucky and she got 10, grams per week, she would have, even more so. But the bare minimum we would expect would be from her hemoglobin, for her hemoglobin to go from 90 to 110 grams per liter. This is the typical algorithm I use, and feel free to adopt it, where we start with, our ambulatory care patient. And again, we're not dealing with our unstable patient here or the patient that imminently needs surgery. We've got a bit of leeway with this type of patient. Let's say you're starting your ferrous, you're adding vitamin C plus or minus, you're looking at the underlying bleeding issues. You're assessing then for tolerance, and if they tolerate it, you recheck the hemoglobin in 4 weeks, 2 to 4 weeks. That's going well. With the hemoglobin rising 5 per week at the bare minimum, you may get more. If that's a yes, great. Continue until their hemoglobin's at baseline. It may be 120, which is the typical WHO value for hemoglobin, and the ferritin is 50. And there is some data that keeping a female's ferritin around 50 plus does improve symptoms, quality of life, cognitive symptoms, etc. So that's what I aim for, and it's a pretty easy number to remember as well. Okay, in the alternate case, let's say they take the hemoglobin, let's say, isn't appropriately rising, assess for any major other losses, probably menstrual still in the population we're sharing together, could be GI. And then I'd like you to think about giving IV iron or parenteral iron at that point, if they're not appropriately incrementing. If they're intolerant of iron, you can switch to second line iron types like polysaccharide, or the heme iron, which I didn't touch much on. That's a bovine iron. It's quite expensive though, and it's not for all religious groups because it does have some cow meat in it. Or you can try the every other day, even though it really hasn't panned out. If you've got a well-adapted patient who isn't really unstable, and they're kind of really still thinking about just pills, you may think about an every other day strategy. I don't tend to find that really works, to be honest. I try it at the patient's insistence, not really mine, but nonetheless, it's something to think about. If they're intolerant of that, you can go back to your strategy of thinking about parenteral or intravenous iron. And then again, you give that intravenous iron until their hemoglobin's where you want it and their ferritin is 50 plus.
So thank you, Karima. That's very, very helpful. So in our patient who has heavy menstrual bleeding, and she has, we start immediately on non-steroidal anti-inflammatories and tranexamic acid. Because number one, we want to stop the bleeding. Number two, we want to treat the iron deficiency. Just so to summarize, as a gynecologist, I was always doing, Ferromax once a day. But in this patient, what we'll do is we'll start an iron salt like ferrous fumarate, or and we'll do that daily. We'll say to take it in the morning. We'll say also give with some vitamin C. And we'll also tell the patient about side effects and perhaps taking a laxative at the same time. So that's going to be the counseling point. And these slides are available after, so that some of the items here can always be imported, hopefully, into your EMR or to patient handouts if you wanted. So the second question is, what investigations do you order next? And in any patient, I would suggest, that has heavy menstrual bleeding, should at bare minimum get a CBC and a ferritin level. Not all anemia is going to be iron deficiency, and a lot of us practice in very cosmopolitan, multicultural centers, and that's our patient population. So I also add on a hemoglobin electrophoresis right off the bat in patients who have heavy menstrual bleeding. Also, we want to get advanced imaging and ultrasound and a cavitary assessment, sonohistogram, if it's available in your area. And this again is a reminder that although that there are various causes of anemia and that iron deficiency accounts for over 60% of anemia globally, there are other causes of anemia. And there are thalassemia traits, there's sickle cell traits and disorders, and these are things that we see frequently in our practice. And that's the justification for starting off right off the bat with the CBC, the ferritin, and the hemoglobin electrophoresis. So 4 weeks later, we have a telephone call with the patient to follow up, and we ask her how everything is going. The NSAIDs and the TXA are working well, but the menses are still heavy. We ask about compliance with iron, and she says, oh, she's not very compliant. She takes it during her period because she feels weak at that time, but the iron does make her nauseous and does make her constipated despite taking laxatives. The ultrasound that I look at in my chart is classic of the ultrasound we get in many centers, a large bulky uterus with innumerable fibroids between 3 to 7 centimeters, and a submucosal component of the intramural fibroids are likely. I review the blood work, and her hemoglobin is 90, MCV 76, and her ferritin level is 9. Her hemoglobin electrophoresis is normal. So what are we going to do next? Right away, number one, we want to stop the bleeding. We probably want to do a better job than we've done already. So we're going to start GnRH agonist suppression to help shrink the fibroids and hopefully prepare the patient for surgery, because the second thing we're going to do is put our patient on our already long waiting list for an abdominal myomectomy. And then we look at the second step really was to treat the iron deficiency anemia. And we look at the blood work here, the hemoglobin of 90, MCV, and the ferritin. And Karima, I'm going to ask you again to help us out here as a gynecologist is what do we make of this blood work, and how do we go about interpreting it, and what do we do with it?
Mm-hmm. Yeah, so we've already established that this person is having some side effects, some compliant issues right off the hop. This is a typical consult I would get for perioperative optimization of hemoglobin. That hemoglobin of 90, I'm not happy with going into a potential surgery. So for those 3 reasons that I've stated, I'm going to think about giving parenteral iron at this moment. Interpreting the data, it's a bit of a slam dunk. We'll move to the diagnostics, and I'll tell you why. Any ferritin under 30, so hair ferritin is 9. To me, I don't feel we need to order any more iron studies to chase any further, iron parameters. We have a very uncomplicated case. She's not highly comorbid. The ferritin of 9 is a slam dunk. This is iron deficiency. Now, where you may get into esoteric arguments is, well, what's 30? Is it a ferritin of 20? Is it a ferritin of 15? There's consensus amongst hematologists, and that those papers are one of our iron experts, Michelle Scholzberg in Canada. I would consider her one of the leading experts in Canada, has really put forth a position paper arguing for this ferritin of 30 micrograms per liter. I won't delve into that in the interest of time. If you have a highly complex patient, you would want to then think about ordering the TSAT, not off the hop, but take a look at the history, the other comorbidities. And then if you think that level, the iron indices are going to be more accurate because the ferritin, being an acute phase reactant, may be all over the map. If that TSAT or iron SAT's under 20%, you've also got to consider iron restriction or a frank iron deficiency anemia in that patient. And of course, she's microcytic with a small size cell. This patient was tested for essentially beta thalassemia up front and something like sickle cell disease with the hemoglobin electrophoresis. A hemoglobin electrophoresis is an excellent first step in our big cosmopolitan centers with these microcytic anemias for ruling out sickle cell and beta thalassemia, at least off the hop. What it doesn't do, unfortunately, is the other type of thalassemia, which I can see sometimes in my practice, the alpha thalassemia. So let's say you fix this patient, and there's probably not a big rush to get into this, but if she's not, having any further bleeding, her ferritin's corrected, and she's still microcytic, that's when you want to consider that, reach out to your hematologist at that point.
Thank you, Karima. So that's helpful. So for the gynecologist, a CBC and a ferritin a ferritin less than 30 is essentially diagnostic of iron deficiency, is what I'm hearing. The one thing is that for this patient, we've put on our waiting list for elective myomectomy, and this is hopefully going to be a fertility sparing surgery because the patient does want to get pregnant. And in this study that we did in Ontario of over 16,000 patients who underwent elective hysterectomy or myomectomy for benign conditions between 2013 and 2015, it was striking that 1 in 4 women undergoing these procedures were anemic on the day of surgery. And we know that anemia in these patients in our province these patients who are anemic were at increased risk of death, postoperative complications, and return to hospital. And they were at increased risk of blood transfusion. Well, we found that if you went from a hemoglobin of 100 compared to a hemoglobin of 130, the patient who was 100 had 4 times more likely to get a blood transfusion. And in a patient who we're trying to do elective myomectomy for, that blood transfusion that we give at the time of surgery may have implications for her reproductive outcomes and during her pregnancy, where we know that 1 in 8 women actually end up having alloimmunization during pregnancy from a blood transfusion that they've had. What was even more striking, and I think that when we're talking about patient blood management, the number 1 step is really diagnosing the anemia. And what we found is that nearly half of women undergoing these procedures, which are elective procedures, were not tested for anemia in the 60-day interval prior to surgery. And when we compared the risk profile of these patients who were not tested compared to those who were known not to be anemic, we found that the non-tested patient had an increased risk of transfusion and complications. So the one takeaway message is that any patient that you put on your surgical waiting list, please, please, please do a CBC and a ferritin, because think about correcting that anemia. And when you look at multiple, this has really become a quality metric for us. And if you look at multiple societies in Ontario, Health Quality Ontario, the SOGC, the World Health Organization, the Australian and New Zealand societies, all say that we should be aiming for a hemoglobin of at least 120 prior to elective surgery. And there's a group of anesthetists and an international consensus that are saying that, in fact, we actually have to go higher than 120 and aim for the bar of 130 in optimizing patients preoperatively. So here we are. We have our patient who has a hemoglobin of 90. We've put her on the waiting list. We want to get to that hemoglobin of 130. That's what the international societies are saying. And the big question in my mind is, how do we get this patient there? What is the iron deficit of this patient? And here's the poll, and we'd love if you could answer. Is the iron deficit A, 500 milligrams? Is it 1,500 milligrams? Or is it C, 3,000 milligrams? Or is it, I actually don't know?
Dr. Murji, we're getting a unanimous response. I'm just going to give a couple of more clicks there. I think you will be, this was my answer, so I'll share that with you in 1 second here. Let's share the results. There we go.
Perfect. And this is exactly how I was, 6 months to a year ago, where I actually had no idea. So I'm going to turn it over to Dr. Khamisa here to kind of help us out, to say that we want to go from 90 to 130. What's the iron deficit and how do we correct it?
Well, it's a very interesting question, Ali, and very few people know this particular method of trying to get to point A, from point A to point B. If you ask somebody, if you were to transfuse a unit of blood, most of us, even from medical school, would know that that 1 unit of blood should raise you 10. And so if you want to go from 90 to 130, well, there's 4 units of blood. Hey, no, we don't want to do that. Remember, we're trying to conserve and not give blood. So let's try to finesse our way through this. We won't get analysis paralysis with this Ganzoni formula. I wanted to show it to demonstrate that there is a method to giving IV iron that is based on somewhat of a calculation where we look at the body weight, and excellent, we'll go to the next slide. In fact, we'll just jump into this example right here where we want this 80 kilogram woman, we want her at 130. We have our hemoglobin right now is 90, so we can take the difference. We can add a little bit of iron of 700 milligrams into a storage form, and we calculate that out, and this is how we would want to give her, and how much iron we would want to give her is about 1,500 milligrams. So looking back to the previous poll, I believe whoever said 1,500 milligrams, I'm not sure the percentage, but that's the correct answer. Now that's a very complicated formula, and I haven't used that formula. I don't use it all the time. If I'm really struggling or the patient's behind the 8 ball, I'll probably try to be a bit more precise with my iron calculations. But as a rule of thumb, when you have a patient with their hemoglobin and their iron deficient, ferritin under 30, hemoglobin under 100, you can assume without calculating a thing, their iron deficit is going to be 1,000 milligrams. And I'm going to show you how to correct that. Now, they may have ongoing periods. It's just like pumping in a tire. You can pump in air. If you've got a leak in the tire, you're only going to get that air out. So the iron may leak out if they have a very, very heavy menstrual cycle. But 1,000 milligrams is the number I want you to remember. If you're thinking about repleting with IV iron, try this number. And let's go to the next slide to see if we can actually figure out what we're going to do. So you can tell the patient if they're going to resolve that 1,000 milligram deficit to go and eat 500 steak dinners. That's not very practical at all. These are small steaks with a bit of iron, 165 tablets. So that's over 4 months of daily ferrous sulfate. And so that's great for when you're not in a hurry, the patient isn't bleeding too much, they're tolerating, etc. That may be useful, or there's a few months at least of the polysaccharide iron, but again, absorption may be an issue. And this is what I want to focus on here. So if you want to give them parenteral iron, these are the number of treatments and doses that you would need to get that patient at least started. You may need to give more, but at least get started. You can give them 5 treatments of IV iron sucrose. So just for your audience, IV iron sucrose is Venofer, and it's what's used in pregnancy after 2nd trimester in Canada. It is the only parenteral iron product approved in Canada at this point in pregnancy. That may change. There's a study in Saskatchewan using iron isomaltoside in pregnancy. The data isn't here yet, so we're going to wait for that. Or you can give 3 treatments of 300. You can give a newer product, which I'm going to talk about, called iron isomaltoside, or ferric dairy maltose, it's called, another name. You give 2 treatments of 500. And in the age of coronavirus, where we're trying to limit the number of times people go in and out of hospital, our hospital, the Ottawa Hospital in Ottawa, Ontario, Canada, is now on compassionate basis, allowing our perioperative and urgent cases to have compassionate doses, a one-time dose of 1,000 milligrams of IV iron, recognizing that 1,000 is about the right number that we want to correct that deficit. That limits their exposure to in and out treatments. Okay. And again, I think we could recognize the benefits of 1,000 milligrams, just overall well-being, cognitive function, etc. Let's get into the sticks of the 2 products that I think you should know like the back of your hand. I don't tend to prescribe Ferilicet, or the middle product is called ferric gluconate, so I'm actually going to leave that. The 2 products that I'd like to focus on are iron sucrose, which I think many of you have probably prescribed. It's been on formulary since 2001 at our institution, probably, I want to say, a bit longer. And then the newer product, the total dose iron, called ferric derisomaltose, or iron isomaltoside. And that was introduced in 2018. And who shouldn't get IV iron? So we've just discussed briefly who should get IV iron if you're not tolerant, not compliant, peri-op, pre-op, etc. But you shouldn't get IV iron if you've had a prior allergy to another type of iron product that does put you at a bit of a higher risk potentially. If you've got iron overload, apparently 1st trimester pregnancy is listed in the textbook of, definition not to give. I give it when the benefits outweigh the risks. So there are certain people you probably would want to avoid IV iron in, and theoretically, if they've got an active infection, sepsis, etc., you kind of want to avoid giving IV iron at that point. So what scares people about IV iron is dealing with the side effects. And I think people are comfortable with side effect counseling with respect to oral iron. It is about 70%, up to 70% of patients. But actually, at the end of this talk, I'd like you to be very comfortable with snipping this one part of the slide, the right part of the slide, into your clinical notes. If you have an EMR or an electronic medical record with pre-populated templates, I'd like you to be able to say, and I counseled the patient on the following infusion or the following possible reactions to intravenous iron, because I think intravenous iron should be in your toolbox. And what's interesting is that the frequency of intravenous iron is actually far less, much less than what people think it might be. But they are significant and you have to be very comfortable. So the most severe thing, the most severe side effect that you can have with intravenous iron is obviously an anaphylactic type reaction, and that is extremely rare. So in 10 years, I've been paged once, and that one patient who had it actually discussed with me, you know, she did have an iron dextran reaction in the past. We thought perhaps we could get away with pre-medicating, but she ended up having, you know, still a reaction. Was my only one. I tried twice. That's very, very rare. But to recognize that patient's going to have very typical symptoms of anaphylaxis. Now, these intravenous iron products are given in medical day units, so they often are very, very well managed, or they're well recognized by the staff at the day units. But certainly they should have in-services and education sessions about managing any medication that they're giving. The nurses really do run the show in these day units, and they contact me. I'm never more than a page away. And I haven't had any problems in 10 years, less than one patient. If you're a patient, if they call you, if you're on the ward, you're a gynecologist, you're prescribed some IV iron, and you were called to assess a patient with the following symptoms, stop the iron infusion first. Again, it's rare, but I just like to tell you what to do. Consider the use of epinephrine and hydrocortisone. That should be part of your toolkit for managing any anaphylactic reaction, bronchodilators, ranitidine, etc. And then we have the 1 to 5% of patients who I vigorously counsel about this issue, because this is far more common. I manage patients' expectations. I tell them the risks. I tell them the benefits. And I do tell them that in a few percentage, up to 5% of patients, you will get some flushing, some headache. Some people actually for a day feel flu-like symptoms after having their IV iron. And it doesn't really matter if you're at the total dose, the bigger dose, newer irons that we're using, or the lower dose iron sucrose type products. It tends to be the same. We list the same percentage in terms of side effect counseling. There is a truncal type chest and pressure called a Fishbane reaction that you should do an in-service or counseling to your patients and your nurses about how to recognize that. And slowing the infusion down. I try to give these doses over an hour. I don't really push. You can push some of the IV iron products. I tend to like to just give them slowly. Including the newer products. And if a reaction does happen, if they get a few hives, you can think about Benadryl. Benadryl's falling a little bit out of favor. You can give cetirizine, which is less sedating, hydrocortisone, IV, obviously stop the infusion. The nurses would do that. And then just watch and wait. And if they're fine oftentimes. Now there could be delayed issues where they call you at home and say, oh, I've got a bad headache. Tell them this will last about 24 to 48 hours. They can take, Tylenol, fluids, hydration. If they've got flushing at home or hives, they can take a Benadryl at home, but of course counsel them to return to the emerge if they have any shortness of breath. And again, I just want to manage their expectations. These barely happen, but I'd like, everyone to be aware of them.
Karima, that was really excellent, because in the past, what I would have done in, let's say this patient is I wouldn't have recognized that this patient actually had at least 1,000 milligrams of deficit. And I probably would have sent for IV iron, just a Venofer, for example, 200 or 300 milligrams. And I would have said, oh, that should do it. But in fact, I think what you highlighted very nicely is that when the iron deficit is 1,000, you probably need 3 doses of 300 of iron sucrose, or 1 dose of one of the high dose irons like isomaltoside. What is super interesting for a gynecologist is that without 2 seconds, we think about calling for blood, but the risks really for the IV iron are far lower than blood. So when should a gynecologist prescribe IV iron? As you've talked about, the intolerance, non-response, or poor adherence to oral therapies. In any patient with heavy menstrual bleeding and has a hemoglobin of less than 90. So in our patient that we're talking about here, on her first visit, knowing that her hemoglobin was 90, we could have started her with IV iron, and that's a recommendation from Health Quality Ontario. Rapid correction of anemia, especially when you have surgery booked within 6 weeks, or if patients feel really crummy and you really want to correct their anemia quickly. Patients who have medical and surgical conditions with decreased absorption, inflammatory bowel disease, it's an example for that. And what I want to remind everybody here is that we all do surgery, and post-operatively, anemia is not very well treated. And if a patient is anemic with a hemoglobin of less than 100 post-operatively, that patient post-operatively is not going to tolerate oral iron very well, and it's not going to be absorbed very well. And that is an indication for IV iron post-operatively also. So back to our case, our patient ended up getting 1,500 milligrams of iron isomaltoside over 2 doses. She had GnRH agonist treatment for 6 months, and then her hemoglobin was corrected at 123. She underwent uncomplicated surgery, 300 cc's of blood loss postoperatively, and she was discharged on post-op day 2. So I hope that we've kind of brought everything together here today for this patient on how we really improve the care of our patients with heavy menstrual bleeding. And just to highlight a few points, number 1, ask patients about iron deficiency symptoms. Number 2, for every patient with heavy menstrual bleeding, draw the CBC, ferritin, and or the hemoglobin electrophoresis, either initially and or definitely at the decision to undergo surgery. Have fail-proof mechanisms so that we don't miss the anemia, so the patient doesn't show up in the operating room and we look and we see that the patient's been anemic. Counsel about oral iron and start with an iron salt. Think about that iron deficit that we have. Remember, if your hemoglobin is less than 100, your iron deficit is 1,000. And then, of course, think about IV iron. I'm going to hand it over to Sony now. Thank you for your attention.
Wow, that was fantastic. Dr. Khamisa, Dr. Murji, you guys did a great job. Lots of positive feedback. Murray, we're going to try to get ourselves all on the screen now as we go into our question and discussion part. But as we're doing that, I just want to remind people that this will be available as a recorded webinar on our website this upcoming week. Also, don't forget to, in the chat, you will see your link to get your maintenance of certification section 1 credits with the Royal College. Once you do the survey, you will get the certificate. Next, I do want to thank again the sponsors who make this possible, and the memberships as well. Just want to remind you that AbbVie, Allergan, Hologic, Pfizer, and Tercera have been a critical part of the team. And finally, in January, very excited, I'm going to be working hard with this team to provide online modules to go over some of these things as well. And so, Ali, we're going to get you to stop sharing and we're going to go live. I have some really great questions. We are going to go over time a little bit, and remember, we're going to record. So there we all are. Okay, now I'm going to jump, taking the moderator's privilege here, to jump to a question that it doesn't exactly have to do with IV iron or PO iron, but you've got the hematologist on. We all have a question when we're controlling bleeding. Tranexamic acid was brought up, and the question of the century is tranexamic acid and the OCP together. You know, it's not a contraindication in Canada, but in the US, we see it as a label contraindication. give us some of that. Is that okay, Ali?
It's not a contraindication. And I think Ali probably has more data, but Michelle Scholzberg has, instilled in us not a contraindication. You can give it both.
Great. I just wanted to be sure we heard it from you, and I appreciate that as well. One common question is, what is the frequency of giving the IV iron? So one of our colleagues, Dr. Haddad from Montreal, is asking, as well as some others, is it weekly? Is it, how often can you give it?
So it depends inpatient, outpatient. In the ambulatory care setting, if you have an urgent surgery, 6 weeks or less, I try to give it weekly to try to really get them stacked up with their iron, their hemoglobin. Each week you give the IV iron, often a Venifer or iron sucrose 200, and get a good 10 gram increment, just like you would with oral, but that's a different issue because now we know 100% is going in the body versus 10%. So we're getting, depending on the nature of their surgery, when it is, we give it every week. My non-urgent patients, we have a little leeway. Some surgeries, unfortunately, are bumped 4 months down the road. So I space it out every 2 weeks. Do I give it more frequently in a week? Yes, I recently had a young lady who was pre-op hysterectomy. They called me on a Wednesday with a hemoglobin of 78. Their Friday morning surgery was there. We did our best because we knew we had to control her heavy menstrual bleeding with a hysterectomy. And then post-operatively, I gave her daily IV iron, but she was inpatient at that point in order to meet that 1,000 milligram deficit.
So I just want to clarify so I get it right here. So you can give it weekly, you can give it every 2 weeks.
Yep, that's the typical dosing.
But the main reason to spread it out is because of reducing the risk of side effects, or
no, it's
better outcome?
100% practical. From unfortunately, with our day unit, we have very limited space.
Okay.
So when we do, unfortunately, try to book the weekly, we need to rationalize it by saying they have an urgent surgery. So it's a resource issue, unfortunately.
So you could give doses daily for 3 days.
Inpatient, I do that, yes.
Yeah, okay,
With
perfect.
Jehovah's Witness, people that refuse blood all the time.
I have a few more questions. Sorry, a lot of them are for you, Dr. Khamisa. In terms of electrophoresis, if you have a Caucasian woman, would you do that automatically? We heard from Dr. Murji, he does it routinely in everybody. I'm worried about the cost of that. If there is a cost that's significant, but or do you reserve it for ethnic background patients such as Asian patients, etc.?
I reserve it for somebody who has achieved the ferritin of 50 and remains microcytic with no other good reason. I've had Polish people with this, blue-eyed, with thalassemia. It's in French, Italian, Mediterranean, Greek. It is, it's probably not the easiest answer. My highest priority is the people from certain ethnic backgrounds who really makes a difference. The other folks, I probably am a bit more selective. Again, that's my practice. But in an multi-ethnic center like Toronto, there may be certain nuances and that may be appropriate in that center. In my center, it's probably, we're a little bit more selective.
So what is your advice to Dr. Murji, or Dr. Murji, do you want to respond? You said you do.
I actually disagree with that, Sony, because it's hard for us to know. I do obstetrics also. Exactly. It's hard for us to know what somebody's ethnic background is, but just by looking at them. And especially in obstetrics in Toronto, I practice downtown Toronto. Everybody gets it, and it's surprising the things that I pick up. And especially in pregnancy and with the booking blood work, I do it just because it does have implications for patients. So where I work, that's what I do. I've had discussion with Christine Lett from Saskatchewan about the same thing, and she actually doesn't do hemoglobin electrophoresis because she works in a different type of setting. So I think it does definitely have to be practice center dependent.
So I have a question from a colleague of mine who actually ran our special unit where we actually had a hematologist and a gynecologist together dealing with bleeding disorders. So she has a lot of experience. Her question is, are any iron supplements covered by insurance companies? And is it true that if we give a prescription for iron, the patient doesn't pay taxes on the iron? And I'll add to that, I just learned that there are actually Ontario drug benefits, at least in Ontario, will cover some irons as well. So cost and coverage.
So we definitely have a nationwide audience. I scanned the 112 participants, so I should caution that this is a provincial, province by province situation. And in the province that I'm in, practicing Ontario, ferrous fumarate and gluconate are actually covered on our ODB, or our Ontario drug benefit. Polysaccharide iron, we have a lot of government workers here in the city that I work in Ottawa. And we have people with very good drug plans. And in fact, the polysaccharide iron, if you put it on a prescription, it's actually covered. I don't believe there's tax on any of them, on any of the, I don't believe there's tax on medication. But again, I could be wrong. I'm just trying to think of my own prescriptions, and I don't believe I'm paying tax on them. But again, maybe the dispensing fee.
I think one of the things that I've learned is I went to the pharmacist. So usually I look at all the contraceptives and, other things to see how much they cost. Yesterday I went and looked at the iron cost at Shoppers, and, it was incredible that the price variation and the pennies you would pay with some irons, yet, significantly more with others. So I think there is a responsibility for us to learn. So I heard it is covered by many private insurance companies, depending on what coverage you have, but look at your drug benefits for those who perhaps can't afford typical irons as well, because $5 a month for ferrous fumarate is a huge difference versus $30 or more for others. There is a question, I would go amiss if I didn't include our gynecologist question. So do we have information on what is the expected improvement in hemoglobin per week on oral iron in chronic inflammatory states like active malignancy? I think the question is there a difference if somebody's quite ill, perhaps not losing blood, but needing some support?
That they may not increment at all. We still try to aim for 5 to 10, and there is some literature arguing that in that particular context they'll get nothing because of a molecule called hepcidin, which may be very high in certain inflammatory states. So if they've got nausea because of chemotherapy, they may actually benefit from intravenous iron. Now I'm keeping my eye on a little bit of data as well, and I'm looking for it as it comes down the pipeline, because iron is essential to infections. It may be, I don't want to give too much, because I do sometimes worry about what we don't know. Does iron drive malignancy? Erythropoietin was a drug that we use to boost cells, and is there an oncologic potential that we don't know about? So I do limit it on a case-by-case basis. I do give IV iron to people with malignancy to prepare them for surgery. I'd rather do that than give them blood transfusions. And I don't find it's definitely on a case-by-case basis, but they may not increment at all with oral iron. It depends.
I think
it's not too much. Giving too much is bad as well for these cases. That's what you're doing.
Yeah, I would try to kind of, if you're giving iron, the ferritin's over 200 and you've got a great percent iron sat, I sometimes back off quite a bit on their supplements.
Dr. Murji?
I think, Sony, the take-home point with that 5 to 10 grams per liter increase that we've kind of honed in on for this talk, I think the message really is to retest and see if there's improvement. And when you retest, also ask about tolerability, because that helps guide your decision making. So less important just exactly the number, but I think it's just that whole constellation.
Now, you've answered a couple of questions directly, Ali. I just wanted to make sure that we got the audience to hear some of those questions. So one of our colleagues has asked a little bit about what other tests do you do in the chronic kidney disease patient, etc. And Ali, you seem very familiar with the saturation test. Is that something you order on your own too, Ali, or when do you order that?
Yeah, so I think that it all depends on, and for me, it's been really an evolution in how much I'm getting to learn about this with time and speaking to various different colleagues. But I think the take home for the general gynecologist who is hopefully listening to this webinar is the CBC and the ferritin less than 30. Those are the basics that we need to know as gynecologists. And then, of course, if there are the complicated patients, these are the patients that I'm sure our hematology colleagues are more than happy to help us out with. But in my practice, I will order iron studies for patients as a second line. I won't do it first line, and then help interpret some of those values. And then, of course, if it's getting more complicated, then I will send directly to hematologists, and all the studies have already been done. So it's easier for the hematologist to do.
So that's something you've talked to them about. So right now you've done your CBC, your ferritin, your hemoglobin electrophoresis. And then if you still needed more information, Dr. Khamisa, you had said it would be the TSAT test that we would order in order to help define a little bit more.
Absolutely. Yeah. And then there's definitely other causes of anemia in pregnancy. Rare, of course, but we do see them, and we're going to be the ones to see them, where they're multi-system, multifactorial often.
So I just want to hit this home. There are cases where the ferritin will be high because of these inflammatory states. So that's where you do the saturation test.
Correct.
Right. The other thing that some guidelines have said is that you do a CRP to see if there is high inflammation state, and then you know that your ferritin is falsely elevated.
Perfect.
But at the end of the day, if we can just get every gynecologist to do a CBC and a ferritin, I think that we will serve our patients so well, because we're all going to be starting to think about anemia and how to correct it, and then we can triage patients appropriately.
So I think we're probably going to end up with our last question, or maybe two, because we had said we're going to go 10 minutes over only. There is a question about I'll ask it in a different way. The question was about preoperative blood transfusion. Dr. Khamisa, you gave us an example. I've got surgery on Friday. I'm not going to cancel. Why don't I just give her a couple of units? What's the harm in that?
Well, this is a situation, and there are some surgeries where patients are, quite acute and really do need and not, need it delayed. I find that I've had Jehovah's Witness patients who I've actually approved urgent orthopedic surgery with a hemoglobin of 60 because the benefits of that surgery, it was a car crash, they needed it, they went for it, they did surprisingly well. It's not optimal. It really isn't optimal. We need a month's notice for these things. Yes, it is done from a practical standpoint. The patient that I was referring to got a unit of blood, before, and, intraoperatively as well, but postoperatively IV iron. Had I had known a month before, I would have been able to appropriately do that. So I would say, wait lists for obstetrical issues, they're long enough sometimes that we have the leeway. But in urgent cases, this woman was bleeding. Her anemia was not going to get any better by delaying her hysterectomy. In fact, by pushing it to an unknown date, we would have been chasing our tails. We made a decision with keeping the surgery, giving the unit of blood, getting it to just 90. It wasn't optimal. I recognize that. But we also sometimes have to be a bit practical too.
And the other issue is what Dr. Murji had shown, that the risks are greater with giving blood transfusion than iron. So that has to be taken into consideration. That's why we're not
and minimizing how much blood we give, really.
Let me
Sony, I just want to say one thing on that. I think when we're talking about this, we're really talking about quality improvement. And when we start bringing it to our colleagues to say that there are going to be exceptions. There are going to be patients who are going to need blood before their surgery, but that should not be the majority of patients. And when we look across GTHA hospitals, when anemia rates are 30, 40%, and there's variation between 10% and 40%, the excuse that, oh, all of my patients need surgery and we can't stop their bleeding and they need to go to surgery, that's not good enough, really. So there are going to be exceptions, and we all recognize that, but that shouldn't really be the rule of thumb.
So I do want to just touch point that you mentioned, Ali, a post-op IV iron transfusion. I think people are talking more and more about this. Dr. Khamisa, he had mentioned that as well. It's a question out there too. Is that something? So, many of our patients are anemic post-op because they've had some bleeding. Should we just go ahead and give the IV iron automatically, or is there value in, topping their blood up because you have to give them a blood transfusion and then just holding, solid from there?
I tend to prefer that if their hemoglobin has fallen below 100 with a potential discharge after 2 days OR, my personal preference as somebody who's going to try to scramble to get IV iron potentially as an outpatient, they've been flagged to my attention because they're perhaps intolerant already of pills. That's why they come to me. So my own personal experience for somebody who's perhaps, and go back to the history, Sony, if that person's been poorly compliant with iron, on and off, poorly tolerant, I would just give a baby dose. And this is what we did with this lady, Vena-for 200. She told me on the phone, we did a virtual visit. She said, I wish I would have known about IV iron I've been tired my whole life. Like I've been like this and nobody told me. No, and that really hit home, that I think we're just underutilizing a fairly safe product, potentially, to the detriment of our patients. And it's hard to get an IV iron as an outpatient where I practice. It's much easier to get it as an inpatient. And I think that's my bias.
So Karima,
yeah.
can I ask, so let's say I have a post-operative patient, right?
Dr. Murji, I have to stop. So we will have to, on that note, that was a perfect summary, but we are quite a bit over and I've gotten the message we're going to close. So, but we have the opportunity to follow up with our online modules in January. You're going to hear more about that and you're going to watch us live. I want to thank everybody for being involved. Don't forget to do your evaluations. And if you do have further questions, you can always get a hold of us through CanSAGE and we can pass them on to address them at the modules as well. So thank you, Dr. Murji. Thank you, Dr. Khamisa.
Okay, thanks.
Bye.
Bye.
Okay, take care, everybody.
Bye-bye.